Let's talk about alpha 1 antitrypsin deficiency. What are proteases? All the enzymes that break down proteins, they are called proteases. Alpha 1 antitrypsin is basically a protease inhibitor. So, alpha 1 antitrypsin will stop all the protease to control the normal body function. Let me give you an example. So, if we see here, neutrophil elastase. Neutrophil elastase is a protease. It means it will do the degradation of the normal protein structure in some of the pathogens like bacteria, and by this neutrophil elastase will kill the bacteria. Now, alpha 1 antitrypsin is a protease inhibitor. It will stop neutrophil elastase to not degrade the protein structure of the alveolar wall. It also functions in other areas, but mainly in the alveolar wall there is elastin, and neutrophil elastase can break down this elastin in the alveolar wall. So neutrophil elastase will kill the bacteria, and alpha 1 antitrypsin will stop neutrophil elastase from breaking the wall of alveoli. What happens when there is deficiency of alpha 1 antitrypsin? There is no negative force, or there is no inhibition of elastase. So what it will do, it will go down after killing bacteria. It will also damage the wall of alveoli. It means all the alveolar walls are damaged, and we will find pan SNR, uh, a bigger area we call emphysema. So it will cause that. Before we move into this, so now we know alpha 1 antitrypsin is a protease inhibitor. What is protease? Breakdown of protein. So neutrophil elastase, a protease that will kill the bacteria. Alpha 1 antitrypsin will prevent this from damaging the normal alveolar wall. But if there is any deficiency, the wall cannot stay there. So before we continue, I want you to keep this in mind. So it is like 1, 4, but if you see, it is also A and it is also 1. Alpha 1, A, and T. Alpha 1 antitrypsin. But you can also appreciate 4. It is basically alpha 1 antitrypsin deficiency code is on chromosome 14. Now I have also put two organs, not very clear, but you can appreciate lungs and liver. So this is the whole pattern of alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin will form in lungs and then they can be transferred to lungs where they will stop neutrophil elastase from breaking down the alveolar wall. Now if we see here, okay, so this is basically for MCQ, we will come to that later. Let's see what happens to each organ. So as we mentioned here, lungs and liver, this is the whole area of alpha 1 antitrypsin. Let's talk about lungs. What happened to lung? As we discussed, there will be a damage to the wall, and ultimately we will see emphysema. I have made this pan is in our bigger areas, emphysematous areas. What will happen to liver? Because now alpha 1 antitrypsin is abnormal, so instead of alpha 1 antitrypsin going out to lung, it will start accumulating in the liver. And once its concentration is high enough, it will start damaging the liver tissue and ultimately can cause steatosis, fibrosis, and it will go up the scale to cause cirrhosis ultimately. So suppose here, first of all, inflammation, and then hepatitis, fibrosis, cirrhosis, cancer, and obviously here it can also cause jaundice, full static picture of jaundice. If we talk about the lungs, mostly the lower lobes will be affected. It will cause emphysema. Clinical features are worsening shortness of breath, cough, frequent infection. So this is basically something about clinical feature. Now, If we talk about the genetics of alpha 1 antitrypsin deficiency, so we will cover this topic and then we will quickly go through how the MCQs will be made for this. We know it is autosomal recessive or in the codominant fashion, and mostly in the MCQs you will see father father died in 50s. Yeah. So now there are three alleles M, S, and Z. Z is very slow, S is slow, M is normal. So it means protease inhibitor MM, two pairs, person is normal. If it is MS, some issues. If it is MZ, a little bit more issue because the other part is very slow. People with MZ, if they don't smoke, they are carrier, but they don't usually get emphysema. Yeah. But with double Z, it is the most severe form of the disease. And mostly, if someone is showing all the clinical features of liver and lungs, like cough, worsening shortness of breath, or AST is high, ALT is high, and increased bilirubin, then we need to think the genotype could be this because it is the most severe form. Apart from that, concentration wise, if it is with double S, then normal A1AT concentration will be 50%. If it is with double Z, the normal level will be 10%. So we can see why the situation will be worse in EI double Z. Let's talk about investigation. We know there is a deficiency of alpha 1 antitrypsin. We will check the level. There are problems with the lungs. We can do spirometry, chest X-ray, CT scan. We can also do simple blood test like LFTs. I should write here. Yeah. So we need to do LFTs as well and also gene phenotyping like this. What is the phenotype? If we talk about management, non-pharmacological management related to the liver, we need to make sure the person is vaccinated against hepatitis B because they are more likely to get liver related issues, so they should be vaccinated. If we talk about the lung, the person should stop smoking because smoking can worsen this breakdown. Smoking worsen lung disease. If we talk about pharmacological thing, we need to give alpha 1 antitrypsin concentrates. If we talk about lung related issue, bronchodilators, maybe we can do some reduction surgery or lung transplant. If it is liver medication, we need to give diuretic for symptomatic treatment and ultimately liver transplant. So this is alpha 1 antitrypsin. So quickly, alpha 1 antitrypsin on chromosome 14. If it is liver abnormal accumulation leading to hepatitis, fibrosis, cirrhosis, cancer at the far end, it can cause increased AST, ALT. To the lung, it can cause emphysema. Mostly MCQ will come someone, sorry, so not someone, father. Father has died in the 50s. This is the most, so now this is the thing I was mentioning earlier. So this is the MCQ picture. Family, father died in 50s. All the liver related issues will be mentioned, jaundice, pruritus, lung related issues will be mentioned, and then it can ask what is the diagnosis or what is the management. So now we know the management, alpha 1 antitrypsin concentrate or to treat symptomatic liver or lung related issues, or so they both are a liver or lung, so you can remember this area. Now, specifically MCQs. So as we can see, father died in 50s, high LFTs, non-smoker, but some smoking history in the past, lung features positive, EAS is positive. It is basically a specific test in the liver biopsy that will help us to diagnose alpha 1 antitrypsin. But to be honest, you don't need to be very specific or go into the detail what is EAS. Although we know diastase, globulin, and the other detail, but we don't need to talk about this for MRCP1. Another MCQ's father died at 52, jaundice, 8 to 10 cigarettes per day, chest X-ray showing emphysema. Uh, and what is the diagnosis? Alpha 1 antitrypsin. Okay. So, talking about some other MCQs, area wise, it is most common in Caucasian or Scandinavian people. So, if someone knows that they have got this alpha 1 antitrypsin issue in the family and they want to protect their lungs, because the earliest thing, the first lung will be affected and in the later stage liver will be affected, they need to stop smoking. Here, alpha 1 antitrypsin stop emphysema by elastase inhibitor or protease inhibitor function. We have discussed that before. So that's it. So the final MCQ. So I have accumulated all these MCQ basically, although it is here 6, but I think it was at least 21 MCQs from different sources. Young non-smoker presented with shortness of breath. We saw liver part, jaundice, increased ALT, AST, cirrhosis, sorry, lung-related issue, liver-related issue. So the disease is, what is the phenotype? What was the answer? It was PIZ or PIZZ. Also, this phenotype or genotype is also linked to the early onset emphysema. So this is all about alpha 1 antitrypsin deficiency you need to remember. Yeah. Let's move on to the next topic.